Good morning and welcome to the press conference for the 2017 annual meeting of the Society of Thoracic Surgeons. I'm Dr. Robin Cohen, Chair of the Workforce for Media Relations and Communication. Our next paper will be introduced by Dr. Jeff Jacobs from the Johns Hopkins All Children's Hospital.
Well, good morning, everybody. My name is Jeff Jacobs, and I'm a pediatric heart surgeon at Johns Hopkins All Children's Hospital. I also chair the Society of Thoracic Surgeons National Database Workforce. The STS National Database is the largest database in the world capturing operations for thoracic and cardiac surgery, and the STS Congenital Heart Surgery Database is the largest pediatric heart surgery database in the world. One of the important findings from both the STS National Database and especially in the STS Pediatric Database is that outcomes vary across hospitals that do heart surgery. And the Society of Thoracic Surgeons believes that patients and their families have the right to know the outcomes of the treatments that they're going to receive. We believe that as cardiac surgeons, it's our professional responsibility to share this information with patients and with their families in a language and in a format that they can understand. And because of this belief, the Society of Thoracic Surgeons began publicly reporting outcomes of cardiothoracic surgical operations, initially in 2010 with adult cardiac surgery, and more recently in 2015 with pediatric cardiac surgery. In the Pediatric Cardiac Surgical Database of STS, the Society of Thoracic Surgeons Congenital Heart Surgery Database, over 95% of the heart surgery programs in the United States that perform pediatric heart surgery submit data. So there's a high penetration of participation. 60% of those programs now submit data and agree to have that data transparently, publicly reported. This next paper from the team at the Children's Hospital of Philadelphia is an extremely important paper that examines the format and structure of how it might be best to share information about cardiac surgical outcomes with patients and their families. STS has studied multiple different strategies, and currently we use a method where we report outcomes utilizing a categorical system of star ratings and also augment that with detailed specific data with point estimates with confidence intervals. And we continue to study and explore better ways to share this information with our patients and with their families. And with this quick background, I'd like to welcome the team from Children's Hospital of Philadelphia to come up and share some very important findings that they have generated in collaboration with parent support groups that I think in the future will help inform the way STS chooses to publicly report outcomes as we move forward and as we, I guess, augment and improve our public reporting strategy. So I'll turn the podium up to the team from the Children's Hospital of Philadelphia and Dr. Irons. And congratulations for this excellent work.
Thank you, Dr. Jacobs, for the introduction. So today we're going to be talking about parent preferences regarding the public reporting of outcomes in congenital heart surgery. The team has no disclosures to report. Recently, an increasing demand for the public reporting of pediatric heart surgery outcomes has led to the development of several different reporting schemes, including a hospital star rating system and procedure-specific mortality data tables for the STS benchmark operations. However, despite the availabilities of these reporting schemes, there remain unanswered questions about the optimal format and content of public reporting for pediatric heart surgery outcomes. The star rating system used by the STS assigns 1, 2, or 3 stars to hospitals performing pediatric heart surgery. A 2-star rating represents expected performance. 3 stars are given to hospitals performing better than expected, while 1 star is assigned to hospitals performing worse than expected. In contrast to the STS star rating system, the Pennsylvania Healthcare Cost Containment Council has adopted a different approach, reporting tabular hospital-specific discharge mortality data for each STS benchmark operation separately. These procedures have been determined to represent more homogeneous patient groups. Shown here is the PHC4 mortality report for the Norwood procedure. This table displays the total number of patients undergoing the Norwood procedure at 3 institutions in Pennsylvania and reports operative mortality in both number and % of children. The top row represents the STS average. The preceding two display types emphasize that how data is presented may be just as important as the data itself. However, noticeably absent from these frameworks is parent input regarding the information they deem necessary to make an informed choice about their child's care. Failure to consider this perspective may contribute to suboptimal reporting and misunderstanding of the data presented. The goal of our study was to identify parent preferences regarding the content of pediatric heart surgery outcomes reports, specifically with respect to the type of data that is included, as well as the optimal format for presentation of this data. To identify these preferences, we developed a questionnaire to assess parent attitudes about public reporting of congenital heart surgery outcomes. We designed the survey in conjunction with 3 parent advocacy groups: Mended Little Hearts, the Pediatric Congenital Heart Surgery Association, and Sisters by Heart. The survey was pilot tested among clinical and non-clinical staff in the Department of Cardiothoracic Surgery at CHOP. Parents were solicited for participation in the survey if they were members of one of the parent groups and elected to receive electronic communications from their respective group, or if their child had undergone an STS benchmark procedure at CHOP. The survey was distributed via email to parents in April 2016 and remained open for responses for 1 month. After a month, we received 1,909 survey responses, nearly 1,300 of which provided complete data for analysis. Nearly all of the participants who responded were mothers of children with congenital heart disease and were on average 37 years of age. Nearly all participants were white. Our survey population represented a variety of educational backgrounds, with 1/3 having attained a bachelor's degree and other significant proportions having completed some college credit only or having completed postgraduate studies at the time of their child's diagnosis. Most reported household incomes in excess of $65,000 per year, but lower income households were also significantly represented. Characteristics of the children of survey respondents was also collected. About half had been diagnosed with congenital heart disease prenatally, and 2/3 underwent an initial repair in the neonatal period, defined as less than 1 month of age. Parents were asked to rank categories of outcome measures and other types of information to include in an optimal reporting scheme on a scale of 1, most important, to 8, least important. The figure above displays the results of this ranking. Here, circles to the left of the figure represent a higher ranking, while circles to the right of the figure represent a lower ranking. As you can see, parents identified survival statistics, surgeon-specific outcomes, and complications as the top 3 categories of measures to report publicly. Least important to parents were other services offered at each center, as well as the cost of treatment. You're about to see 3 graphs similar to the one presented here, which display parent preferences for outcome measures stratified by socioeconomic factors. Shorter bars again represent higher rankings, while longer bars represent lower rankings. On the y-axis are several groups, which in this case stratify survey respondents based upon the highest level of education they had achieved at the time of their child's diagnosis. What is important to note in this figure is that the pattern of rankings holds constant across differences in educational backgrounds. This pattern also holds constant across differences in household income and across differences in parent race or ethnicity. In addition to identifying parent preferences regarding the type of data that should be included in an outcomes report, our survey presented parents with 3 potential formats for displaying mortality data and asked them to select the best and worst options. Choice A was the hospital's overall star rating. Choice B was a procedure-based numerical format, and choice C was a procedure-based graphical format. This figure depicts parent preferences for the various display types presented in the survey. A bar extending to the left side of the graph indicates that parent found that display format to be the worst format, while bars extending to the right indicate that parents preferred that particular format. As you can see in the figure, the majority of parents identified a procedure-specific numerical approach as the best display format. Similarly, the majority of parents felt that a star rating system was the worst potential display format. These display preferences also appear to be stable across educational background, as well as household income and differences in race or ethnicity. There are several limitations to our study. First, our participants represent a fairly homogeneous group. Second, the internet-based nature of the survey limits valuable input from those who do not have internet access. Similarly, the availability of the survey in English only prevents non-native English speakers from contributing. Additionally, our survey is retrospective in nature. That is, we've asked parents to report their attitudes regarding the information they deem necessary to make a choice that they have already made. Finally, while we have identified what types of information parents want, we must acknowledge that small case numbers limit the presentation of certain types of data, such as surgeon-specific outcomes, in a statistically meaningful way. Based on this survey, we've shown that parents rank the following as the most important outcome measures to report publicly: survival statistics, surgeon-specific outcomes, and complications data. Importantly, these preferences appear to be stable across differences in education level, household income, and race or ethnicity. Additionally, we have shown that parents strongly prefer a procedure-based numerical display format, such as the tables in the PHC4 report, for the presentation of outcomes data. This finding is also stable across differences in socioeconomic factors. The implementation of public reporting in congenital heart surgery is not without challenges. The development of an optimal reporting system requires a common database in which to collect and analyze data, a robust methodology for risk adjustment, and a way to compare performance across a field that is inherently heterogeneous. The ideal public reporting system should be valid as well as easily understood by all stakeholders. While our survey has helped to clarify what types of information parents want and how they want it to be displayed, we must recognize that just because parents want certain data, that does not mean we can provide this in a meaningful, statistically valid way. Perhaps the most important takeaway from our study is the importance of involving parents and other stakeholders in the design and planning of methodologies for public reporting of congenital heart surgery outcomes. Ultimately, the optimal platform will represent a melding of what parents want and what is statistically meaningful and valid. Thank you. I'd be happy to take any questions.
Questions, Dr. Irons? Yes.
Crystal Fenn with MedPage today. My question for Dr. Jacobs. Does the STS have any consideration of dropping the star rating based on findings like this?
So first, I would congratulate our colleagues from CHOP for, I think, a very meaningful study, and this information is important. STS has worked over the past several years in collaboration with the Pediatric Congenital Heart Association, and we've attended and participated in several transparency summits that this parent advocacy group has had, and we really do place very high value on the opinion of parents and of families. STS currently reports both the star rating and also the actual data associated with the star rating. So we don't do just one approach. We have the star rating, and then by clicking on that star rating, the actual data with the mortality and the confidence intervals around the mortality is also available. We believe it's important to report the data in both formats because of the fact that not all families can readily understand confidence intervals, and the star rating system makes the concept of confidence intervals more available to those that don't have the statistical background. So the current STS approach is to report data both in the format advocated in this presentation with the actual data with confidence intervals, but also to provide the star ratings to make that information a little bit more accessible to some of our patients and their families.